Months of revenue. That is what one payer audit can claw back when you blur the line between PHP versus IOP. Payers are increasingly sophisticated at auditing level of care decisions, and partial hospitalization billing carries the greater audit exposure. The difference between these two levels is not just hours per day, it shapes your staffing model, licensing, payer contracts, and reimbursement. In the next few minutes, clinical criteria, hours, staffing, billing codes, and the reimbursement math behind each level. On the ASAM continuum for substance use disorder, PHP is level 2.5 and IOP is level 2.1. Partial hospitalization is the most intensive level of care short of inpatient or residential. Structured, time-intensive programming with no overnight stay. Intensive outpatient sits one step below structured treatment while the patient manages work, family, and school. The dividing line is utilization review's central question. Can the patient sustain gains between sessions, or do they need daily containment? Here is what is at stake when that line blurs. If your PHP census is sustained by patients who clinically belong in IOP, you are building on a foundation that cracks under audit pressure. A single payer audit of your PHP billing can generate recoupment demands that dwarf months of revenue. Reimbursement math favors PHP, but so does risk. Higher staffing costs, more prior authorization management, and greater audit exposure. This is exactly the context Behave Health's integrated EHR and revenue cycle platform is built for. Level of care documentation, designed to support the placement decisions payers expect to see documented. Utilization review workflows, designed to help your team keep step-down decisions documented. And payer-specific billing rules, because the complexity of PHP and IOP management is why generic software fails. 4 dimensions separate PHP and IOP operationally. Hours, clinical criteria, staffing, and billing codes. Let's take them one at a time. Dimension 1, hours. PHP runs 6 or more hours per day, 5 to 7 days a week. 30 to 40 treatment hours weekly. IOP runs 3 to 4 hours per day, 3 to 5 days a week, 9 to 20 hours. Under ASAM, level 2.5 means a minimum of 20 hours per week. Level 2.1 means a minimum of 9. Dimension 2, who belongs where? PHP fits patients at acute risk who do not require 24-hour supervision, often stepping down from inpatient or residential treatment. IOP fits patients stable enough to manage daily responsibilities while receiving meaningful treatment support. Placement is assessed across 6 ASAM dimensions, from withdrawal risk to the recovery environment. Dimension 3, staffing. Most payers require daily or near-daily psychiatric contact in PHP, and they scrutinize it heavily in utilization review. A registered nurse is required for PHP in most states and by most payers. IOP carries a lighter staffing footprint, a prescriber available but not daily, with monthly medication management typical. Dimension 4, the codes. PHP and IOP use distinct code sets, never swap them. For PHP, H0035 is the most widely used code, with S0201 used by some commercial payers. For IOP, H0015 is the most widely used code for substance use, with H2036 and S9480 used by some Medicaid and commercial payers. Modifiers matter too. HF for substance abuse programs, HK for co-occurring. Verify active codes and units with each payer. Now, the rates typical market ranges, never a substitute for your actual contracts. In-network commercial PHP typically runs $350 to $800 a day. IOP, $100 to $300. Medicare pays PHP through ambulatory payment classifications, and only hospital-based and hospital-affiliated programs can bill it as a per diem. Payer mix is the primary lever. One commercial authorization at $600 a day generates more than 3 Medicaid authorizations at $200. The step down from PHP to IOP is where clinical judgment, payer expectations, and operational efficiency intersect. Step down when symptoms are manageable without daily monitoring, the safety plan is functional, and the patient uses coping skills between sessions. Gaps between levels, even 48 to 72 hours, are a significant relapse risk factor and a documentation vulnerability in appeals. Document every step down with the same ASAM dimensional framework used at admission, including the scheduled start date at the next level. Keep the line between PHP and IOP clear, and keep it documented. See level of care documentation, utilization review workflows, and payer-specific billing rules. Book a demo at thehavehealth.com.